Diabetes is a condition that affects how your body uses sugar, glucose, a key source of energy. In this video, we introduce the basics of diabetes, its types, common symptoms, and why managing it is essential for a healthy life. Today, two guests, Alice and John, will guide you through this important topic, explaining it in a simple and easy-to-understand way.
Imagine, just for a second, that you're standing right in the middle of the most lavish, massive buffet you've ever seen in your life.
Oh, wow. Okay.
Yeah, like mountains of fresh food everywhere, right, literally within arm's reach. But there's this horrifying catch. Your mouth is taped shut, and your hands are tied behind your back.
That sounds like an absolute nightmare.
Right. You are literally starving to death while surrounded by this virtually endless supply of energy, just completely unable to consume a single bite of it.
It's a really visceral image. I mean, it sounds like something straight out of a psychological thriller. But if we zoom in, to a microscopic level, that exact scenario is a perfect description of a biological paradox that's happening inside the bodies of millions of people every single day.
Which brings us to today's deep dive. We are taking on a pretty massive mission today, trying to decode the hidden cellular mechanics of diabetes mellitus.
Yeah, a condition that affects, a staggering 10% of the entire global population?
Yeah, exactly. 10%. So, to figure out what is really going wrong inside the pancreas, the bloodstream, the cells, we are leaning heavily on a really deeply detailed medical transcript from Osmosis from Elsevier.
And, to really grasp the gravity of this, we kind of have to start with the baseline of how your body manages fuel in the first place.
Right, when things are working normally.
Exactly. For you, the listener, your body is engaged in this constant, delicate high-wire act. It's constantly managing how much glucose, which is the primary sugar that powers your existence, is circulating in your blood versus how much of that sugar actually gets inside your cells to be, burned as energy.
And this entire operation is managed from this very specific control room, right, down in the pancreas.
Yeah, specifically in these tiny clusters of tissue called the islets of Langerhans.
Right, which is just a great name.
It really is. They're basically these tiny islands of hormone-producing cells just floating within the pancreatic tissue.
Okay.
And there's a really strict division of labor here.
Okay, break that down for us.
So in the center of these islets, you have beta cells. Beta cells produce insulin, and that's the hormone responsible for lowering your blood sugar.
Got it.
Then surrounding them, on the periphery of the islet, are the alpha cells, and they produce glucagon, which is the hormone responsible for raising blood sugar.
Okay, so we have these two hormones doing opposite jobs, but I want to really visualize what insulin is doing here because from the sources, insulin doesn't actually grab the sugar and carry it into the cell, does it?
No, not at all.
It's more like a bouncer or maybe a delivery dispatcher that just unlocks the doors.
That is a great way to look at it, yeah. You have all this glucose floating around in the bloodstream, but it can't just barge through the cell membrane of your muscle or fat tissue.
Because it's locked out.
Right, the cell membrane is like a fortress wall. It needs an explicit invitation to let anything inside. So insulin travels through the blood and binds to these really specific, specialized receptors on the outside of the cell.
It's knocking on the door.
Exactly.
And when it knocks, something fascinating happens inside the cell. I mean, looking at the osmosis transcript, the cell has these little internal storage bubbles, right, called vesicles, and they're packed with glucose transporters.
Yes, and think of those transporters as literal doorways. When insulin binds to the receptor on the outside, it triggers this massive chemical cascade on the inside.
So the cell reacts to the knock.
Right. Those storage vesicles rush to the cell membrane, they physically fuse with the wall of the fortress, and they just install those doorways.
Wow.
Suddenly the wall opens up and the glucose that's been waiting in the blood just floods inside to be used for energy.
So the dispatcher unlocks the system, the doors open, and the fuel gets dropped off.
Exactly. But the body always needs a counterbalance.
Yeah.
And that's where glucagon comes in.
Right, the other hormone.
Yeah. If insulin is the storage hormone, glucagon is the mobilization hormone. They are on this constant teeter-totter. Like if you haven't eaten in a while and your blood sugar drops a little too low, the alpha cells release glucagon.
And where does that go?
It travels straight to your liver and forces it to do two things. One, break down stored complex sugars. And two, generate brand new glucose from scratch.
Oh, wow.
Yeah, and it dumps all of that into the blood to keep your brain and your body running.
It is just a brilliant, beautifully calibrated system, but I guess that delicate teeter-totter completely collapses if the delivery dispatchers, the beta cells, are systematically hunted down and destroyed by your own body.
Which brings us to type 1 diabetes.
Right.
This accounts for roughly 10% of all diabetes cases. And fundamentally, type 1 is an autoimmune condition. It's a catastrophic failure of the body's internal security system.
So the immune system has this army of T cells, right? And their entire job is to patrol the body and assassinate foreign invaders like viruses or bacteria.
They are highly trained assassins, yes. And normally, the body has a really rigorous training program for these T cells. It's called self-tolerance.
Self-tolerance. Okay.
Yeah, before T cell is released into the bloodstream, the body tests it to make absolutely sure it doesn't accidentally recognize your own healthy tissue as an enemy. If a T cell fails that test, it's immediately destroyed.
But in type 1 diabetes, that quality control process just fails. A rogue T cell slips through the cracks.
Unfortunately, yeah.
And it leaves the training ground holding this like molecular wanted poster that perfectly matches the beta cells in the pancreas.
That's exactly it. And it doesn't just attack on its own. That rogue T cell recruits a whole militia of other immune cells. They infiltrate the islets of Langerhans and coordinate this devastating targeted strike entirely against the insulin-producing beta cells.
While leaving the alpha cells alone.
Completely untouched. It's wildly specific.
The osmosis transcript points out that there are actually genetic clues as to why this happens in some people. It traces back to chromosome 6, specifically something called the HLA system.
Right, the human leukocyte antigen system.
Yeah.
Think of HLA as sort of like the serving platter that your cells use to present molecular fragments to the immune system.
Like saying, here is what I look like.
Exactly. People who develop type 1 often share very specific genetic variations of this platter, namely markers called HLA-DR3 and HLA-DR4.
So those specific platters might be accidentally presenting the beta cell's own proteins in a way that looks threatening to the T cells.
Precisely. But, it's crucial to note that having those genetic markers is just a predisposition.
Right, it doesn't guarantee you'll get it.
No, plenty of people have HLA-DR3 or DR4 and never develop diabetes. It usually requires some sort of environmental trigger, like a viral infection, to kick the immune system into that hyper-aggressive state.
But whatever the trigger is, the destruction is terrifyingly quiet. The sources note that a person can lose up to 90% of their beta cells before they ever feel sick.
Yeah, the body just keeps compensating until the factory is almost entirely burned down.
But when that threshold is finally crossed, the symptoms hit incredibly hard. And clinically, doctors look for 4 classic symptoms. They all start with poly, which means many or a lot.
Right. Polyphagia, glycosuria, polyuria, and polydipsia.
Let's unpack the underlying physics of those symptoms, because they really tell the whole story of the disease. But wait, hold on. I want to stop at that first one. Polyphagia, which means extreme ravenous hunger.
Yes.
If my pancreas is destroyed and there is no insulin, my blood is absolutely flooded with sugar from the food I'm eating. If I am quite literally bursting with energy in my bloodstream, why on earth is my body acting like it's starving?
Because of that fortress wall we talked about earlier.
Yeah.
It doesn't matter how much food is sitting at the buffet if your mouth is taped shut.
Oh, right.
Without insulin to act as the messenger, those cell doors never open. The muscle and fat cells are sitting in an ocean of glucose, but their internal sensors are registering zero fuel. They panic. They send out these emergency signals screaming, "We are starving to death."
So the body switches into survival mode. It literally starts cannibalizing itself.
Yes, it flips into a hypercatabolic state.
Yeah.
The adipose tissue, your fat reserves, starts breaking down fat molecules to release emergency energy. And the muscle tissue starts breaking down its own proteins. The person's losing weight rapidly and feels this intense, insatiable hunger polyphagia because on a cellular level, they truly are starving.
That perfectly explains the first symptom. Now, what about the blood itself? All that unused sugar is just piling up in there, which brings us to glycosuria sugar in the urine. I imagine the kidneys, which are basically the body's water filtration plants, must be taking an absolute beating trying to process this syrup.
Oh, they are completely overwhelmed. As blood passes through the kidneys, they filter it, and normally they reabsorb all the valuable glucose back into the body.
Because you don't want to lose energy.
Exactly. But there's a hard limit to how much they can handle. When the blood glucose level gets too high, it hits a saturation point. The kidneys physically cannot grab it all, so the excess sugar just spills over into the urine.
And sugar isn't just a passive molecule, right? It's osmotically active. It acts like a molecular magnet for water.
This is where the physics really takes over. Wherever sugar goes, water is forced to follow to try and dilute it. So as all this heavy glucose dumps into the urine, it drags a massive amount of the body's water out with it.
Which causes the third symptom,
Right, polyuria, or massive frequent urination.
which logically leads directly to the fourth symptom. If you are constantly draining your body's water reserves down the toilet, you are going to become severely dehydrated. So your brain triggers polydipsia, an extreme, unquenchable thirst.
This is a brutal cascade,
Right.
but unfortunately it gets worse.
Oh, boy.
That panicked survival state we talked about, where the fat cells start breaking themselves down to provide emergency energy, that process doesn't just cause weight loss. It unleashes a potentially lethal chemical chain reaction known as diabetic ketoacidosis, or DKA.
Okay, let's break this down because DKA sounds incredibly dangerous. The fat cells are releasing these free fatty acids into the blood. Where exactly do they go?
They head straight to the liver. The liver takes those raw fatty acids and synthesizes them into an alternative fuel source called ketone bodies.
Oh.
The main ones are acetoacetic acid and beta-hydroxybutyric acid. Now, the complex names don't matter so much. What matters is that word, acid. Ketones are highly acidic.
Hence the name ketoacidosis. The ketones are literally poisoning the blood by dropping its pH level.
Exactly.
And the body desperately tries to fix that acidity, right? Using the lungs, oddly enough.
Yes, it's a fascinating compensatory mechanism. Patients in DKA will suddenly start breathing in a very deep, labored, rapid pattern. It's called Kussmaul respiration.
So they're hyperventilating.
They are instinctively hyperventilating. And why? Because carbon dioxide in the blood contributes to acidity. By blowing off massive amounts of CO2 through heavy panting, the body is desperately trying to reduce the total acid load and stabilize the blood's pH.
But the lungs can only do so much. The osmosis transcript describes this massive, complex chemical shift happening at the cellular level involving potassium.
Right.
If the blood is incredibly acidic, that means it is absolutely flooded with protons, right? Hydrogen ions.
Exactly. And the cells, they try to act as lifeboats. They have a specific membrane transporter that swaps protons for potassium.
Okay.
To get those dangerous acidic protons out of the blood, the cells pull them inside. But to maintain their electrical balance, every time they pull a proton in, they have to kick a potassium ion out into the bloodstream.
So the cells are sacrificing their own stored potassium to save the blood, which means if a doctor draws blood at this moment, the potassium levels are going to look incredibly high, right?
It will show severe hyperkalemia, high blood potassium.
Yeah.
But this is where the biological trap springs. Remember the massive urination we just talked about?
Right, the polyuria.
All that excess potassium floating in the blood gets swept up by the kidneys and flushed right out of the body.
Oh, wow. So the blood test is a false comfort. The test says there's plenty of potassium, but the total reserve in the whole body is actually completely depleted. It's just passing through on its way out.
Exactly. And potassium is critical for your heart to beat correctly. If a doctor doesn't realize the total body stores are actually empty, treating the patient can be fatal.
What I find so terrifying is how easily this entire DKA nightmare can be triggered. The sources mention someone with type 1 diabetes could just catch a mild flu or like a urinary tract infection.
Yeah, illness is a huge trigger.
And the physical stress of a simple infection causes the body to release epinephrine adrenaline. That adrenaline stimulates the release of glucagon, which further raises blood sugar and signals the liver to make even more ketones. A single stressor just tips the scales.
It's a complete systemic crash.
Yeah.
Clinically, doctors will see what's called a high anion gap on their blood work, which is really just a mathematical way of measuring all that uncounted acid.
And physically, what does the patient look like?
The patient will experience intense nausea, vomiting, and eventually cerebral edema, which is swelling of the brain. Oh, and they also emit a very distinct fruity smell on their breath.
Because the liver is making all those acidic ketones, and one of the byproducts is acetone gas, which is literally the same chemical in nail polish remover. They are exhaling acetone.
It's a huge diagnostic clue for doctors. Saving a patient in DKA requires a really carefully orchestrated intervention. You have to pump them full of intravenous fluids to reverse the severe dehydration.
Right.
You administer insulin to finally open up those cell doors, which stops the liver's panicked ketone production. And you have to meticulously replace those hidden depleted electrolytes, especially the potassium.
So we've established that type 1 is a catastrophic failure of the insulin factory. The beta cells are dead. But what if the factory is working perfectly fine, but the delivery dispatchers are simply being ignored.
Oh, yes.
That brings us to type 2 diabetes, which makes up 90% of all cases worldwide.
This is a totally different mechanism. This is insulin resistance. In type 2, the pancreas is churning out plenty of insulin. But when that insulin travels to the muscle or fat cell and knocks on the door, the cell doesn't respond.
The knock is just ignored.
Yeah, the internal mechanics are jammed, the storage vesicles don't move, the doorways never open.
The sources mention the classic risk factors we all hear about, right? Lack of exercise, hypertension, obesity. But genetics play a huge role too. If you look at twin studies, if one identical twin has type 2 diabetes, the other has a massive risk of developing it, regardless of their lifestyle.
The genetic component is profound, for sure. But the environmental aspect, specifically regarding obesity, is really eliminating. We tend to think of adipose tissue body fat as just inert storage, like a biological closet.
Just sitting there.
Right. But it's actually a highly active endocrine organ. Excess fat secretes signaling molecules called adipokines, as well as free fatty acids.
And these adipokines are essentially chemical troublemakers, right? They trigger systemic, low-grade inflammation all throughout the body.
That inflammation is the key. That constant chemical static from the fat cells directly interferes with the insulin receptors. It literally blocks the signal, making the cells resistant to the hormone's knock.
But the pancreas doesn't just shrug and give up. I like to think of this like a broken doorbell. The cells aren't answering, so the pancreas just decides to mash the button harder.
That's a great analogy, yeah. The pancreas goes into overdrive. To force the issue, the beta cells undergo hyperplasia, meaning they actively multiply to create a larger workforce.
Wow.
And they undergo hypertrophy. The individual cells physically swell and grow larger. They're throwing everything they have at the problem, pumping out gargantuan amounts of insulin just to force a few of those cell doors open.
And the crazy thing is, for years it actually works. They manage to maintain normal blood sugar. But mashing that doorbell comes with a heavy price. The factory isn't just making insulin. Every time a beta cell secretes insulin, it also secretes a little bit of a protein called amylin.
Yeah, and amylin is normal in small doses. But when the beta cells are running at 500% capacity, that amylin just piles up. It starts clumping together inside the islets of Langerhans, forming this dense, sticky plaque.
It's literally gumping up the gears of the factory.
It's exactly. Between the toxic buildup of amylin plaque and the sheer exhaustion of working at maximum capacity for years, the beta cells finally break. They burn out.
The factory collapses.
Right. They undergo hypertrophy, shrinking, and begin to die. That is the moment the blood sugar finally spikes uncontrollably, and the classic symptoms of diabetes set in.
Now, type 2 patients experience the exact same polyphagia, polyuria, all the intense thirst and hunger. But they usually don't go into DKA. Why is that? If their blood sugar is sky high, why doesn't their body start churning out those acidic ketones?
Because of the broken factory. In type 1, there is absolutely zero insulin. In type 2, even when the pancreas is failing, there is usually just a tiny bit of insulin still circulating.
A little trickle.
Yeah, that tiny trickle of insulin is entirely useless at lowering the blood sugar, but it is just enough to keep the fat cells from completely panicking and initiating massive lipolysis. It prevents the deadly ketone chain reaction.
It saves them from the acid, but it sets them up for a completely different nightmare, right? HHS, or hyperosmolar hyperglycemic state.
Which is arguably just as dangerous. Because the glucose isn't being used, it just keeps accumulating in the blood. Remember how sugar acts as a molecular magnet for water?
Right, osmosis, the heavy sugar.
When the blood becomes incredibly dense with sugar, when it becomes hyperosmolar, it turns into a biological sponge. It aggressively sucks water completely out of the body's tissues. The cells are left totally parched and shriveled.
That sounds awful.
It leads to profound total body dehydration that can cause severe confusion, coma, and even death.
Okay, so if all of this immense destruction, the immune system attacks, the amylin plaques, the cellular starvation, if all of this is happening invisibly inside the body, how do we actually catch it? How do doctors figure out where a patient is in this timeline?
Well, it really comes down to medical detective work, primarily by measuring the glucose floating in the blood. The straightforward methods are the fasting glucose test. So if your blood sugar is 126 milligrams per deciliter or higher after fasting for 8 hours, you meet the criteria.
Okay.
There's also the random glucose test, where hitting 200 or higher is a red flag.
But the test that really stands out to me from the reading is the HbA1c test. Hemoglobin is the protein in our red blood cells that carries oxygen. Why on earth are we looking at an oxygen carrier? to figure out how much sugar is in the blood.
Oh, it is a brilliant physiological trick. When blood glucose levels are chronically high, all that heavy syrup doesn't just float peacefully. It physically crashes into proteins in the blood and permanently sticks to them.
Wow.
This irreversible chemical bonding is called glycation.
The sugar literally caramelizes the blood cells.
Essentially, yes. It coats the hemoglobin. Now, a standard blood sugar prick only tells you what the blood looks like at that exact second. But a red blood cell lives in circulation for about 2 to 3 months.
So it's a longer record.
Exactly. By measuring what percentage of a patient's hemoglobin has been glycated or sugar-coated, doctors aren't getting a snapshot. They're getting a 90-day video of the patient's blood sugar history. An HbA1c of 6.5% or higher confirms diabetes.
That is incredible. The sources also detail the C-peptide test, which helps distinguish between type 1 and type 2.
Yes. When a beta cell manufactures a molecule of insulin, it snips off a tiny piece of the precursor molecule to activate it. That discarded piece is called C-peptide.
Like a manufacturing byproduct.
Right. If C-peptide levels in the blood are extremely low or entirely absent, it tells the doctor that the factory has completely stopped production. That confirms the autoimmune destruction of type 1.
Which means the patient requires lifelong insulin therapy. If the factory is gone, you have to import the insulin manually.
Yeah.
Type 2, however, can often be managed early on with lifestyle interventions to reduce the fat-driven inflammation and medications like metformin that force the cells to become more sensitive to insulin.
But the ultimate irony of diabetes is the treatment paradox. Administering artificial insulin is life-saving. But if you get the math wrong, it can be fatal.
You're talking about hypoglycemia, low blood sugar. Like, if a patient injects their insulin but doesn't eat enough carbohydrates to match the dose, what happens?
You've suddenly sent a massive fleet of delivery dispatchers to open every single cellular door in the body.
Yeah.
The cells aggressively vacuum up every last molecule of glucose in the blood.
Leaving nothing for the rest of the body.
Right, especially the brain, which relies entirely on blood glucose to function. It suddenly has zero fuel. The patient experiences intense shaking, weakness, sweating, and in severe cases, loss of consciousness and seizures.
And the treatment for that emergency is getting sugar back into the blood instantly, juice, candy, or an IV push of pure glucose. Or, ironically, giving them an injection of glucagon, the hormone that forces the liver to dump emergency sugar into the system.
It all comes back to managing that delicate teeter-totter manually. Because if a patient cannot keep their blood sugar balanced, if it stays chronically high for years, we enter the final and, frankly, the most sobering reality of this condition, the long-term physical toll.
Yeah, that sticky sugar problem, the glycation, it doesn't just happen to red blood cells. It happens to the physical architecture of the blood vessels themselves.
It degrades the entire infrastructure of the body. Let's look at the microvasculature, the microscopic capillaries. That excess sugar causes proteins to embed themselves deeply into the walls of tiny arterioles. This process is called hyaline arterial sclerosis.
Let's break that down. Hyaline meaning glassy or protein heavy, and sclerosis meaning hardening.
Exactly. It turns these perfectly flexible, healthy biological tubes into rigid, stiff pipes. Furthermore, the basement membrane, which is the foundational layer of the capillaries, actually thickens.
Which means things can't pass through it.
Exactly. It creates a physical barrier that suffocates the surrounding tissue because life-giving oxygen can no longer diffuse across the thick capillary wall easily.
And this vascular suffocation causes a cascade of organ failures. In the eyes, the rigid, dying blood vessels leak, causing retinopathy. Doctors can literally see cotton wool spots or flare hemorrhages on the retina, which frequently leads to complete blindness.
The kidneys are equally devastated. The intricate, tiny arterioles that enter and exit the kidney's filtering units become hardened and damaged. The kidneys slowly lose their ability to filter toxins, a condition called nephrotic syndrome, which inevitably ends in the patient requiring a dialysis machine to survive.
And we have to talk about the nerves. Because of the suffocated capillaries, the nerves in the extremities literally starve to death.
This causes profound neuropathy. Patients lose sensation, usually starting at the very tips of their toes and fingers and slowly creeping upward. It is known as a stocking glove distribution.
Meaning you lose feeling exactly where a sock or a glove would cover your skin.
Yes, exactly.
Which explains the terrifying reality of diabetic foot ulcers. If you step on a piece of glass, you don't feel it because the nerve is dead. You don't realize you have a wound. And because the blood vessels are thick, rigid, and incapable of delivering immune cells or oxygen, the wound simply cannot heal.
It's a perfect storm.
The tissue dies, gangrene sets in, and it leads to amputation.
It is a devastating domino effect. The glycation destroys the vessel starves the dead nerve hides the injury, and the poor circulation prevents the rescue. But, we have to view this in the broader context of medicine.
What do you mean?
While type 1 is an unpreventable autoimmune strike, type 2 diabetes, which again is 90% of cases, is largely driven by environmental factors and insulin resistance. With aggressive lifestyle adjustments, proper diet, and medical management, patients can entirely reverse that resistance, maintain normal blood sugar, and completely avoid every single one of these horrific downstream complications.
It is truly an incredible mind-bending journey that a single molecule of glucose takes inside us. I mean, it is the fundamental, absolute fuel of human life. It powers every thought in our brain and every movement of our muscles. But the exact moment that delicate hormonal teeter-totter of insulin and glucagon breaks down, that exact same life-giving fuel transforms into a toxic, destructive force that hardens our arteries and starves our cells.
And it leaves you with a profound evolutionary paradox to consider.
God, like a paradox.
For millions of years of human evolution, our ancestors lived in harsh environments where food was incredibly scarce. Our biology evolved to fiercely hold on to every single molecule of energy it could find.
Right, survival of the fattest, basically.
Exactly. The biological mechanisms that drive fat storage and even insulin resistance during times of famine were absolutely critical survival traits. They kept humanity alive.
But today, in a modern world, we aren't foraging for berries. We are constantly surrounded by that endless, massive buffet we talked about at the start.
Exactly. The environment changed drastically, but our DNA hasn't caught up. It really begs a fascinating question for everyone listening. Are the skyrocketing rates of chronic conditions like type 2 diabetes actually the evolutionary superpowers of our ancestors, misfiring in a modern world of absolute abundance they were never, ever designed for?
That is a phenomenal thought to leave on. The very biology that saved us in the past is the exact same biology challenging our survival today. The next time you find yourself staring down a massive buffet, you might just look at your own biology a little differently. Thank you so much for joining us on this deep dive into the hidden mechanics of diabetes. Keep exploring, keep questioning the world around you, and we'll catch you on the next one.